He'll take a minute, but, you know, we can move on, we can go ahead and get started. And then we'll just acknowledge him. Because we're 2 minutes short of red. I'll let him finish your thought.
Of next meeting.
We're all good? All right. I'd like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott is absent. Director Garza.
Present.
Director Green. Present. Director Harrington.
Present.
Director Kim. Present. Vice Chair Lowry.
Present.
Director Masuda Bardet. Present. Director Ryder. Stepped away for a moment. Director Robinson.
Present.
Director Sorrell. Present. Director Webster Cross. Is expected remote, but I don't think she's connected. Oh, there she is. Director Cross.
Present.
Thank you. And Chair Taylor.
Present.
Give a quorum.
Thank you. As you heard in the roll call, we have a new board member who was recently appointed to fill the vacancy of Inger Burnett Ziegler. Please join me in welcoming Gina Masuedo Barnett. Perfect. The next regular meeting of this board is scheduled to be held on Friday, July 25th at 9 a.m. But to begin, I'd like to entertain a motion to allow Director Webster Cross to remotely participate in this meeting as a voting member.
So moved. Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor?
Aye.
Aye. All opposed? Thank you. The ayes have it. The motion carries. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Makaitis.
Thank you, Chair Taylor. Good morning, directors.
Good morning.
Right. Thank you, Deb. As always, we'll start by welcoming our new leaders, starting with Ayukunle Abegunde, Chair of the Division of Gastroenterology Medicine, Ping Tang, Chair of the Division of Surgical Pathology, Clinical and Anatomical Services, Amy Melvin, Director of Tuberculosis Prevention and Control, Tuberculosis Clinical Services Program, Department of Public Health, Susan Costello, Director of Nursing Operations, Nursing Services Administration, Candace Mulder, Director of Clinical Research, Research and Clinical Trials, Rebecca Messina, Clinical Nurse Leader, Nursing Professional Development and Education, Kajal Jindal, Physical Therapy Manager, Pediatrics, Physical Therapy, Angela Tefera, Tuberculosis Clinical Nurse Manager, TB Control, Department of Public Health, Lisa Brown-Reed, RN Coordinator, Bed Management, Nursing Administration, Stroger, Delisha Holiday Chapman, Manager of Complex Care Coordination, County Care, Sherry Hurdle, Manager of Operations, Community Health Center, Westside Health Center, ACHN, Frankie Russell, Manager of Quality of Care and Population Health, County Care, Lauren Hollowell, Pharmacist Manager, Pharmacy Inpatient Services, Stroger, Latravia Johnson, Nurse Coordinator 2, Perioperative Nursing, Christopher Asada, Nurse Coordinator 2, Medical ICU Nursing, Darian Garola, Process Improvement Manager, Nursing Staffing Float Pool, Stroger, Vakisha Rachel, House Administrator, Patients, Care Services Nursing, CERMAC. And congratulations to our team members who earned promotions over the last month. Christina Torino, Chief Operating Officer, Health Plan Services, County Care, Juan Ruiz, Medical Director of Dialysis Services, Renal Disease, Paul Allegretti, Director of the Division of Adult Emergency Medical Staff, Providence, Cynthia Washington, Executive Director of Patient Services, Revenue Cycle, George Papadopoulos, Director of Environmental Public Health, Environmental Health, Department of Public Health, Joseph Tevis, Director of Nursing Operations, Nursing Services Administration, Amir Budwani, Director of System Integration and Support, Supply Chain Administration, Laura Ternan Hughes, Mental Health Director, Mental Health Services, CERMAC, Lamont Boswell, Senior Manager of Complex Care Coordination, Community Care Coordination, and Jasmine Sanchez, Senior Project Manager, Strategic Planning and Implementation. And we'll shift to recognition and announcements. And as always, if the team members are in the room, please stand so we can recognize you. And I know everyone heard about the issues at Provident earlier this week. We just wanted to take a moment to recognize the entire team at Provident as well as our facilities team for responding to the heat wave that took out our HVAC system. It was a 24/7 response, and the team stepped up and ensured that we were able to do our very best for patient comfort and safety. Congratulations to everyone there. Thank you.
Thank you very much.
I think.
Thank you.
Thank you. I was gonna say, I see a lot of people who had a hand in this, and everybody's sitting, so. All right, we want to recognize as well our Nursing Clinical Excellence Award winners, Layla Way, Emergency Services Nurse of the Year, and I'm not going to read through them, but please stand and be recognized if you're here. Congratulations to our nursing team.
You're not here. Okay.
Congratulations to our CCH Diabetes and Endocrinology team for being recognized by Becker's Healthcare as one of the nation's great programs. Anybody from Endo? No? Okay. Cook County Health Stroger Hospital was awarded an $18,000 grant from the Toy Foundation's Children's Hospital Play Fund program. The foundation awarded 23 projects at hospitals across the nation, recognizing programs that reflected the importance of play in children's hospitals, particularly those in underserved communities. Congratulations to our Child Life team. We also earned multiple healthcare advertising awards. The Healthcare Advertising Awards, we received Silver Award for Total Health Talks podcast, Bronze Award for the website design, PR News Nonprofit Awards, podcast category, again, Total Health Talks, and internal publication or system briefs. And Astra Awards, we had Gold Award for multilingual advertising for County Care Bring on the Benefits, and surgical services marketing for robotic surgery campaign. And then a Silver Award, again for Bring on the Benefits for overall campaign and TV video advertising, and then social media category for County Care's POV series. Congratulations to our communication.
Yay!
Yeah, absolutely. On June 20th, Cook County Health hosted at our Blue Island location, U.S. Representative Robin Kelly and several local elected officials to talk about the potential impact on Medicaid funding cuts. We continue to advocate to protect Medicaid as a program that's critical to the health of our patients, our members, and our communities.
Sure.
And in honor of Mental Health Month, we led a virtual discussion about tools for mental wellness and discussed the importance of breaking down the barriers that come to seeking out care. And thank you to all the experts who participated.
Thank you.
All right. I don't know if Andrea Gibson is here for an ARPA update. I can just, is she remote? Oh, it's for later. Okay, we'll come back to that. All right. That concludes the first part of the report.
All right, thank you. Appreciate it. Again, welcome to all the new hires. Congratulations to all the promotions and award winners. So thank you. Really appreciate it. Well done. And Craig and Dr. Turner can sleep now. The air conditioning's working. The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We did not receive any registrations nor any written testimony.
What a streak. All right, thank you. The minutes of the May 30th board meeting are being presented for your approval. Are there any corrections to be made to the minutes? Questions? Thank you. If not, I'd like to entertain a motion to approve item 4A, the board meeting minutes of May 30th, 2025.
I'll make the motion. Second.
Perfect. Double move and second. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? The ayes have it. The motion carries. Next, Director Harrington will review the Audit and Compliance Committee meeting minutes. Director Harrington.
Thank you. The Audit and Compliance Committee met on Friday, June 13th at 9 a.m. The next regular meeting of the committee will be held on Friday, July 18th at 9 a.m. The purpose of this meeting was for the closed meeting review and discussion of reports relating to the audit of fiscal year 2024, Cook County Health financial statements and required communications with the external auditors. The review and discussion took place in a closed meeting, and there were no action items presented for consideration at that meeting. Other directors who are not members of the committee also joined us for the review, so we are not planning to re-review the closed meeting reports with the full board today. As I mentioned at the meeting, I'm impressed with the reports that were received. I also want to commend Nicole Amro and Tom Schroeder, both, for their stellar work. I'd like to introduce the external audit team from RSM who are here today. Laura Kalick, partner and healthcare senior industry analyst. Shelby Burgart, senior manager for audit services and healthcare senior industry analyst. And Dan Sethnes, partner. He's joining remotely. I'd like to thank the RSM team for the important work they do. Auditing a complex organization like Cook County is not a simple task, and the intricacies involved in the health and hospital systems component require great skills and knowledge. RSM continues to show that they are up to the task, as they are experts in this field. I'd like to welcome Ms. Kalick to provide any comments on the audit if she chooses to do so.
Thank you, Director Harrington. Good morning.
Good morning.
Good morning.
It's a pleasure and a privilege to be here. I am new to the engagement team and really appreciated the opportunity to work with this terrific organization. So Director Harrington took most of my comments for this morning. I'm here to tell you that you have an unqualified opinion to the financial statements, which is terrific, and that the audit was conducted in accordance with government auditing standards. And as Director Harrington indicated, we did review the report with the Audit and Compliance Committee on June 13, 2025. The organization ended their fiscal year November 30, 2024 with a $635 million operating surplus and an overall positive change in that position of $1.2 billion. So congratulations. It's a difficult thing to do in this environment, so congratulations. So we wouldn't be here today without Shelby Burghardt. Director Harrington indicated Shelby's the senior manager on the engagement team. We're happy to answer any questions anyone may have relative to the audit.
I don't think you have any questions.
Well,
Given
thank you
our
for
very
having us.
robust audit.
Thank you.
We appreciate it. Thank you for your work and supporting us.
Since there are no questions on the minutes, I'm presenting them for the board's consideration.
Thank you. I'd like to entertain a motion to approve item 4B, the minutes of the meeting of the Audit and Compliance Committee of June 13th, 2025.
I'll make the motion.
Second.
Second.
Thank you. Thank you. The motion has been made and seconded. Is there any discussion on this motion? Hearing none. All in favor?
Aye.
All opposed? The ayes have it. The motion carries. Next, in Director Bott's absence, Director Garza will now review the QPS committee meeting minutes.
Thank you, Chairman. The Quality and Patient Safety Committee met on Friday, June 6th at 9 a.m. The committee approved the following action items, which are scheduled to be included in the minutes. Which are included in the minutes. Approved the Stroger Hospital Division Chair initial appointment, and approved Stroger and Provident Hospital medical staff appointments, reappointments, and changes. The committee received the following reports, which are included in the minutes: regulatory and accreditation update. The committee also received informational reports in closed session, but these are not expected to be re-reviewed. The next meeting of the committee will be held on Friday, July 11 at 9 a.m. If there are no other questions on the minutes, they are being presented for this board's consideration at this time.
Thank you. Any questions? Oh, not yet. I'd like to entertain a motion to approve item 4C, the minutes of the meeting of the Quality and Patient Safety Committee of June 6, 2025, which includes approval of the following items. One, the Stroger Hospital Division Chair initial appointment, and Astoria Hospital and Providence Hospital, medical staff appointments, reappointments, and changes.
So, second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor?
Aye.
Aye. Thank you. All opposed? The ayes have it. The motion carries. Thank you. Let's get Director Ryder. I'll be here. We'll come back to Director. Yeah.
I'm ready.
You ready? Thank you.
Thank you. The Finance Committee meeting on June 5th, 2025 was called to order by Chair Ryder. The committee considered the following action items, which are included in the minutes. Conditionally approved 16 contracts and procurement items. Numbers 2 and 7 are pending review by contract compliance. As on the screen, you'll see contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, and they're highlighted for your information. The committee received and filed grant award-related items. The committee then received the following reports: a report on MWBE statistics concerning our work. Second report, a report of 2 emergency purchases that was presented by Charles Jones. Received a report of April financials. We received the monthly report on the agency reduction plan. Requests made regarding the monthly agency reduction report include a request to include the percentage of agency usage by bargaining unit, a request to include the tracking of the positions expected to be transitioned to in-house staff relating to the Guidehouse contract, and a request to include information on the dollars associated with the number of FTEs for the top job code agency use. Are there any questions relative to the meeting of the Finance Committee on June 5th? Hearing none, seeing none, I'll let the chair call the vote.
Are there any questions or discussion on the committee meeting report? Thank you. Director Ryder, any comments on your committee?
No, Commissioner Lowry is did a fine
Professional.
fine
Exactly.
representation of the meeting.
It was seamless. All right, thank you. I'd like to entertain a motion to approve item 4D, the June 5th Finance Committee meeting minutes, which contain the following items: conditional approval of the contracts and procurement items pending review by contract compliance, and receiving and filing of grant award-related items.
Second.
Thank you. The motion has been made and seconded. Is there any additional discussion on the motion? Thank you. All in favor? Aye. Thank you. All opposed? Thank you.
By the way, this is the first time anyone's got to the finance report at 9:20.
We are efficient. Given that, I'd like to recognize and note for the record the presence of Director Ryder and Director Bott, who both came conveniently after their report. We do not have any proposed contracts and procurement items being presented directly to the board. The next item is my report, but I'd like to defer that to later in the meeting, so we can move to the CEO report, which will be reviewed by Dr. Makaitis and Andrea Gibson, Chief Strategy Officer. Sorry, Andrea, come in.
Yes, she is here. Thank you, Chair Taylor. Good morning again, directors. We're going to start with a quick review of ARPA and then continue the march to a finalized strategic plan for 2026 through 2028.
Perfect. Thank you.
Good morning, directors. I'm
morning.
Andrea Gibson, Chief Strategy Officer. The ARPA update this month is that we have now spent $75 million, so up from $70 million last month. So we've continued to catch up on we've had a backlog in payments for some of our subrecipients, and the finance team has worked with the initiative leads to get more of those processed. We still have a number to work through, but we are making progress, and that's showing in the numbers. So we're, again, trying to hit the spending $5 million a month. So we're on track. I'm hopeful that we'll start to pick up a little bit more than $5 million a month in the next couple of months based on the backlog. So any questions on ARPA? All right. Shall we go to the strategic plan update? Great. This will be brief, so where the arrow is in June, we have the draft strategic plan coming to you in the coming days, probably early next week. So we ask that you review that, and we hold it now to incorporate the financial forecast that's linked to the budget. So we'll be bringing it back to you for a vote in July or August once that is complete. So next slide. This is a little hard to read, but what we did I just want to show some of the feedback we incorporated from the last discussion. We added equity to our values and took out the I CARE acronym, and that's displayed here under values. As a reminder, we also updated the mission to, instead of saying establish access, we changed it to provide universal access. Next slide. So also at your request, we put together definitions of the values and worked on folding these in. And really, I think the request from the board was to make sure we had a definition of equity, because as the discussion took place last month, we talked about how equity should be part of all of the pillars, not kind of a separate pillar. So we included that definition here along with the others. Next slide. Now, yes, you can minimize a little. And so this just kind of graphically displays where we ended up on the pillars. We're going with 4 pillars and foundations underneath all of those pillars being equity. Next slide. So a few updates to the objectives and key results that we're proposing, and I underline things that we changed from last time, so we can go to the next slide. Here, there was a request to make sure that we don't lose track of predictive analytics as one of the emerging technologies to leverage in the strategic plan, so that's added here. Next slide. We shifted these 2 objectives to the quality, safety, and experience pillar from equity per our discussion. Next slide. There was also a couple of comments about what our metrics would be. And so we wanted to give you a preview of some of the examples, the high-level examples that we are thinking of. We'll have a more robust metrics development following the adoption of the strategic plan. But as you can see here, it's pushing us to get to the Leapfrog A, the CMS 5 for Stroger, going from a 4-star rating to a 4.5 for county care, increasing incrementally each year the patient experience likelihood to recommend metric, adding or pushing for access to be 30 days for primary care appointments or below 30 days, and new specialty care appointments. Finally, to train 70% of CCH employees on trauma-informed care principles. I think we're roughly at around 10% right now.
So, and your quick question, you highlight these are samples, and you'll have a full or robust list.
Yeah.
5 big things, how many things you have on your list?
Well, yeah, I mean, these are probably the highest
Okay.
level ones. There'll be more, like, there'll be sub-metrics that tie to each of these. And so really, what we were thinking was to have the highest, present to you the highest level.
I think that's the right approach.
All right, next slide. Under workforce, we can go to the next slide. I don't think we changed anything here. Next slide. We are going to, one of the metrics we discussed was reducing the vacancy rate to 10%. We're, I think, roughly at 25% right now, so that's a big goal. Maintain, we actually, as we've reported in this venue, we have a pretty low turnover rate, and so we need to maintain that. We also mirrored the agency utilization goal of reducing utilization to less than 20% by job classification. Next slide. And we can go to the next slide and the next slide. Okay, and there was some discussion last time about factoring in economic development and into some of our focus on structural drivers of health outcomes. So we did add that here. Also, implementing primary, secondary, and tertiary prevention strategies to think about it in that way. So we folded that in here. And these two objectives were shifted from equity to be under transformation and growth. Next slide. Some of the metrics here is to increase our market share for county care to 39%, reduce time to hire to 90 days, and there are a couple procurement metrics relative to new contracts and contract amendments to reduce the contract time. Also, CCDPH is a little bit of a different metric, but completing the community data and capacity assessment that supports the plan for growth in that area. Next slide.
I think you have some questions here.
Oh, I'm sorry.
I have a quick question about your economic sheet. What do you mean by that? Are you thinking about actual, like, investment in economic development?
Not from the health system, but I think partnering, there's a county department of economic development, and there might be some opportunities to partner with them in a way that would benefit our patients. We're not an expert in economic development, so I think it'll be critical that we work with an entity that has more expertise. But they have different programs that some of our patients could participate in, loan programs, other opportunities. So that's the kind of thing we're thinking of.
So, Director Kim, two things. I think our Department of Public Health will probably come closest within the health system to addressing some of those things, like social risk factors, like we were just talking before the meeting. But beyond that, we are positioning with our government affairs and policy team to actually be more intentional and connected with county government and other, state, local opportunities to be, more proactive in that space around economic, opportunities. So partnering with our county team and the government affairs folks over there to ensure that there's policy alignment and that they're aware of the needs of the health system and that we're all kind of working as a team to ensure that those opportunities are met.
I know that Westside United, for example, have been economic investment actually thinking about procurement and employment within their job. Wondering if the county actually is thinking about that approach, or it's just, like you mentioned,
Yeah, no, I think it's a great call out. I mean, we do work with Westside United as well. So I mean, that's a great call out in terms of another opportunity to really try to align and use those resources. So, yeah, thank you.
And will those types of metrics be listed as part of this plan? For example, on the west side, south side, economic structures as well too, and how they may align with what, Providence is doing in further utilization?
As far as the plan goes, we'll keep it fairly high level, but as we, put the action plans together, they'll be accompanied with specific KPIs, like that.
Yeah, so if we remember kind of that cascade that we talked about as we were kind of reworking the last 2 years of the strategic plan, right? It's as we, like, these are system level big, goals, goal strategies. And then we would break it apart so that each kind of division in the organization sees themselves in all those strategies, they understand their role, and it kind of cascades out to the front line so that at every level there's KPIs that are meaningful that they can actually drive improvement on, and that they understand kind of what the role, what the tactic is at every altitude of the organization.
Go ahead, you were gonna.
No, I was gonna move on.
So, one, thank you for incorporating the feedback into the strategic plan. So just appreciate the team's work on that. Two, I agree with Chair Taylor's commentary on quality, safety, and experience, and we can talk about that in committee further. Might even say that there's a stretch goal around Baldrige, but the question on transformation is around Medicaid and the 39%. What's the baseline market? If I remember now, and is that 39%
I think
something
we're
achievable?
34.4, is that right?
35,
Oh,
right.
sorry, Aaron.
So I just think about both on the transformation metrics, how they may relate to other parts of the strategic plan and just what's reasonable to get to.
Yeah, some of these are not easy metrics to get to, but that wasn't the purpose of the strategic plan, right?
Yep.
So, and there's a lot of dynamics, obviously, right now in the country, especially around Medicaid. But it shouldn't prevent us from setting a goal.
And that's over the course of 3 years.
That's right. So by 2028, these metrics would be full.
I took a look back at slide number 66, and we talk about focus on the socioeconomic and structural drivers of health outcomes, and that's an area that we don't have a lot of expertise in, so it's going to require some partnerships with our local elected officials as well as a lot of community-based organizations. I'm sure as we do our planning moving forward, that'll be taken into consideration.
Yeah. All right, if there are no more questions right now, we can go to the last pillar, fiscal resilience, and no changes here, so we can go to the metrics. The simple but big one, maintain a positive operating margin. Again, made more challenging right now based on the landscape at the federal level. And achieving, when a revenue cycle has come before you to present metrics, one of their big goals is to achieve the health care financial, I'm forgetting the phrase. Okay, Healthcare Financial Management Association MAP Awards, which would indicate we are hitting some of the key performance indicators that are reported on routinely to this board. Also, one of our really important initiatives for fiscal resilience is increasing county care member utilization of Cook County Health Services by 20% by the end of 2028. And I think that's my last slide.
That is.
Okay, all right. Any other questions or comments on the strategic plan?
Director
Yeah,
Carter?
just a few comments. I think it's important to note that the plan is really a reflection of a continuation of planning that has happened, and a lot of these goals and key result areas are built upon those that have been successful and that have been improved upon, such as turnover. It's noted here under the workforce area that turnover remains low. as a result of retention programs. I know we've spoken about that in the 5 years I've served as a board member. I know I've seen tremendous improvement just in the last year and a half. And that's, obviously that affects the vacancy rate, turnover rate remains low. And we've sat in these meetings during open testimonials, and we've heard the staff talk about how important these issues are, and I think we're starting to see that needle really be moved. As it relates to the goal, focusing on growth, I mean, we've just been recognized for tremendous advertising, right, that we're doing with the communications team. And so as long as the patient experience is congruent with the marketing, I have every confidence that the growth will happen. In fact, I was sitting with the CEO of another MCO just last week, and that person said, no one does marketing better than Cook County. And that's not only your contemporary, but your competitor. So those are my thoughts, Chair.
Thank you for
been able
sharing.
to say that 8 years ago?
I don't think I would have.
No.
That's the right answer.
Director Green.
Yes, thank you so much for incorporating the primary, secondary, and tertiary. I know a lot of places don't do it because it seems in the weeds, but it's one of the ways to make sure that the delivery of care is implemented and effective, because it allows patients to be incorporated at every stage of what they're experiencing. So thank you for incorporating that.
Director Robinson.
The 35% to 39%, I think that's applicable, and I think it's achievable. Because if we look at in 2026, we have RFP that's coming up for the state for the entire market. At that chance, there's an opportunity because there's going to be a shakeup. Some people are going to make it, some people are not going to make it. And you guys are pretty constant, so therefore that gives great opportunity. And sorry, can't remember. But I like the progression, and I think Alex is a great person to help us get there, and I think it's achievable. I love the aggressiveness.
Yeah.
Okay. All right, if there are no other questions, I think that's it for me.
Thank you very much, Andrea.
All
You're
right.
surprised. You look surprised, Andrea.
Thank you.
No, but that's because of the really good work for the team. So thank you. We really appreciate it. So for everyone, just if you speak, please speak into your mic because everybody can't hear you. We need this, report for prosperity. So thank you. Not you, but others. The next item are committee metrics being presented directly to the board, as those committees did not meet this month. First up is Erin Galiner, speaking of market share, Chief Operating Officer of Health Plan Services, presenting the managed care metrics, followed by Wynn Burren, Chief Human Resources Officer, presenting the human resources metrics. Erin, welcome.
Thank you, Chair. Good morning.
Good morning.
Good morning.
We'll start today with our usual metrics. First up is our membership metrics as of June. We're at 413,000 members, almost 414,000. This is an increase over the prior month, and we've now seen overall enrollment increases for the past 3 months. I'll talk more about the trends we're seeing in the overall Medicaid market here in a second, but I think this is a positive trend versus what we saw at the beginning of the year, where we were seeing some slight enrollment decreases in the first quarter. The next slide shows our overall membership, and so you can see some of those increases that I mentioned. This also lays out 2 important factors in what drives our underlying membership numbers. So the blue bar across or blue line across the top is our redetermination success rate, and so that's also laid out there on the table. We've been right around the 88 to 89% range throughout most of this year, so we've really stabilized around that range. The red line is our choice percentage, which is the number of individuals that come into Medicaid and choose a health plan, what percentage of those individuals are choosing county care. And this has been a really key focus of what we've been working on over the past few years. This started out a couple years ago around the 20% range, and so we've been able to drive that up now pretty consistently over 30%. We would like that to obviously continue to go higher, and so a lot of those efforts around marketing, things we're doing to try to enhance the member experience, all of that, this is kind of the ultimate measure that we look at to see how successful we're being. The next slide shows our market share information. This ties in with our discussion just a minute ago. This data is through April. So you can see that we grew over 35% in total market share. That's the first time as a health plan we've crossed that 35% threshold. In terms of overall market share, a couple years ago, for context, we were around the 32 to 33% range. So we've been kind of consistently outperforming the market over the past couple of years, even through a lot of these big changes with the pandemic, with redetermination. Of course, the HPIA program, which is ending June 30th, when those 16,500 members drop out of our plan, that's going to have some impact on our market share numbers. But we feel good about the trends, kind of the underlying trends that we're seeing outside of that population in terms of our growth versus the market. The other plan here that's seen some growth is Blue Cross. We've been able to continue to kind of widen the gap between us and Blue Cross in terms of market share, but Blue Cross is the other plan that's been gaining market share. Most of that's been coming at the expense, obviously, of Meridian, Illini Care, and Molina. The next slide shows that trend in the overall Medicaid market. So the red line on the right-hand side shows total enrollment in Medicaid in Cook County. So you can see the market has been continuing to shrink pretty steadily over time. This data is only through April from the state. So you can see, we've kind of tracked some of that similar decrease over time on the left-hand side in blue. That's driven by, the redetermination process that was still hitting at throughout the course of last year. We had some flattening out on that trend earlier this year. And then we had some slight decreases, as I mentioned, in the first quarter. When we are able to roll this chart forward, when the data is published and available, we'll be able to show that increase we've had over the past 3 months from April to June, and be able to line up how that's looking across the rest of the market.
Question. On the decrease, so we're roughly about half as slow as the market, so absolutely fantastic from that standpoint. My question is, do we understand why we're able to slow down and decrease?
Yeah, I mean, I think there's multiple factors under our enrollment. So the biggest kind of impact is that redetermination success rate, and we know that we've consistently been a top performer versus the other plans, and just being able to retain people in coverage in our plan. The other main factors are members that get auto-assigned into health plans. That's based on quality ratings, and so because we've had some of the highest quality ratings, we generate some of the most auto-assignments into the health plan when people don't make a choice when they come into Medicaid managed care. And then the third factor is really that choice percentage I mentioned. So historically, we performed really well on the auto-assignment side and performed less well on the choice. So being able to move that choice percentage up the past couple of years has been really critical to us being able to gain that market share, because that's really kind of the main differential we've been able to drive.
With the changes, do you feel as though it's going to impact your ability? Changes being the federal impact is actually changing or potentially changing the rules of who can participate in the Medicaid program or not.
Yeah, I mean, I think there's obviously going to be a likely impact to the total enrollment. I don't necessarily view that as a barrier to us being able to continue to gain market share. It's just that the overall market is going to be more challenged and likely smaller in terms of overall enrollment. I think in some ways it could help us versus some of our competitors to the extent that you have to go through the redetermination process every 6 months rather than every 12, and we're better at that process than others. That could be a competitive advantage to us.
Thank you. I mean, I don't want to misstate this, but the entire market would have to deal with those changes, so it's not, wouldn't be disproportionate to county. And county has some advantages that you just highlighted.
Agreed.
Yeah.
Everyone's gonna, it rains in the room, but everyone doesn't get hit by the same number of drops. It depends on who has the ability to avoid the drops or put up a barrier. So
Right.
that's that's the genesis of the question.
Yeah.
And then, have you been able to isolate any additional factors in regard to I'm looking at the redetermination rate kind of
Director Sorrell, can you reach into the mic?
slowly trending downward, unfortunately. Have we been able to see any of those factors that might increase the likelihood that patients will be able to continue with Medicaid, or to isolate what predictive factors might likely lead to their being removed from Medicaid subsequently in the future, or with any changes? That way we can also provide some type of shore for our patients as well.
Yeah, it's definitely something we've been trying to dig into more. There's some limited data in terms of what we get from the state, which ultimately gives us the delineation between why someone's leaving a health plan, whether that's redetermination or some other reason. I think, there's a few things I would say we have some concerns about. One is potentially some hesitancy of people to continue to re-enroll in Medicaid, given some of the broader concerns around immigration enforcement. And so even those, you may have, let's say, children who qualify for the program, but the adults don't, there may be some hesitancy in the market that we're seeing for individuals to go back through that process. That is not something that's easy to validate in the data, but that is just a broader concern we have around kind of the engagement we see as we go through the process. I also think compared to, there was a lot of market information out there last year around redetermination as that large wave was hitting, and so everyone was kind of out with the message about redetermination, and some of that's pulled back more broadly in the market. And so I think there's a little bit maybe less awareness around redetermination now than there was last year as well. So I think that's part of the reason we've seen some of that trend dip down. And then there is some differential we see in terms of engagement by population. And so we are trying to target some of our work towards some of those specific populations. So especially ACA adults tend to be a little less likely to redetermine, especially individuals in that kind of 20 to 40-year-old age range that often are a little less engaged in care.
Because unfortunately, that every 6 months redetermination change will also make it more potentially difficult to keep those engaged to be able to continue services as well too. Yeah.
Is there a way to put an incentive in place for such? Because if we're going to redetermine at that rate, can we put an incentive that will give the individuals a reason to want to re-up, if you will? And the other question, you mentioned about the hesitancy of members to re-up their children, and that's understandable. I don't think we've had an issue with having to turn over that information, or the other question is, can we put that information into the system in such a way that it does not allow federal to utilize that as a weapon?
Yeah, in terms of the data sharing component, that's all driven by the Medicaid application process with the state. So it's all housed on their systems and how they collect data elements. Even relatively recently, there's a news report about potential data being shared, which flagged a concern. I think we've gotten some additional information from the state stating that there hasn't been data shared up to this point, but I think all of that generated some, initial concerns. So I think that's just the challenge that's out there currently, is a lot of the fear that continues to be in the market around it.
Understood. So the question that I'm asking is, given that knowledge, have we put any thought around how could we actually present to those members a way that we're going to to use academic language, to cleanse the data such that it's not identifiable as to who is who. And you don't have to answer that, but it's just a prompt to maybe say, hey, put some people in a room and let's think about this from a totally different vantage point of how we could possibly do it, and then be able to communicate that to the members to help them feel comfortable with the realness associated with that, that their information is protected. I don't know, because it's a very real problem that's only going to get worse under the current status.
Yeah, I mean, I think it's a good call out, and certainly something we can look at more. Again, a lot of that's driven by the state's process and the data they collect, but we can definitely think through that more. And back to your earlier question about incentivizing, we actually have trialed different incentives over time. We had a READY incentive in place that provided a $50 reward for completing a redetermination form for those that had to go through that process. So some people are automatically renewed, some are required to recomplete paperwork. And so we've also been trying to look at additional opportunities to work with the state around as they're expanding categories of individuals that could fall in that automatic renewal bucket versus having to go through the paperwork, which is obviously a lot more effective way to go through that. So there continues to be different approaches that we're trying to leverage to enhance this, but it certainly is going to be a challenging area.
And one other thing, and it's something I think we need to point out, is no matter how many people we cover, utilization is the most important thing. How many people actually utilize the services that are available. And the problem we have is a consistent, pretty deep drop off of utilization between the population, maybe 30 to about 50. And so it's not what we have covered, it's how people use the care, and do they access the care when they need it, as opposed to actually showing up in the emergency room because they have the flu. And then somebody detects a cancer.
Yeah, that's what the importance of us being integrated and coordinated across both. the
It's
payer
two
provider
perspectives.
side.
I don't think one is greater than the other.
I don't think so, I'm just providing context.
Right, now I was just coming from the financial perspective.
Right.
And that's on the human side, which is equally as important.
Thank you.
All right, on the next slide. This shows our membership versus budget. So we continue to outperform the budget baseline. Of course, as I mentioned, that HBIA impact is going to hit in July. I think based on what we're seeing today, I expect we're actually going to continue to exceed the budget in July. So we are cautiously optimistic that we're continuing to see some of that underlying growth in the Medicaid population, and so that's going to help us offset a little bit of that loss in the HBIA population that we know is coming. Next slide shows some of our operations metrics. Again, these continue to perform pretty well. No real call-outs here, but continues to be a focus area for us, especially as some of these changes are happening, and we know we're going to be getting a lot more outreach and questions from the populations we're serving. Next slide shows our utilization measures. Red bar is prior period, blue bar is current, and we're continuing to see some moderate year-over-year increases in inpatient utilization per thousand. As we've gone through this large wave of redetermination, it's being less driven by population demographics shifting and more just by some underlying increase in utilization within those populations themselves. And so continues to be a trend we're looking at, but overall it's fairly modest at this point. So I don't think any real specific call-outs at this point, but I think as the Medicaid enrollment continues to decrease, we may also continue to see some impact here just in terms of overall utilization. I think the other thing we're monitoring is do we see a sharp uptick in utilization for some of the HBIA population in this last quarter as they try to ensure they get any issues taken care of before they potentially lose coverage.
Question, a couple questions. For those who will lose their coverage, do we have any particular resources that we are directing them to be able to access care, although they no longer have Medicaid?
Yeah, we've been doing a lot of outreach to the HBA population specifically to help them kind of navigate the variety of issues around that, and also helping them understand some of their options. Obviously, Cook County Health, a lot of the federally qualified health centers that they may already be getting care at, and so we're trying to share a lot of that resource information out with them, and then, you know, try to help them have pathways, especially if they're in some sort of active course of treatment, that care is not getting disrupted.
Okay. Okay. Thank you.
Next slide.
I'm sorry. I want to go back to, I have one more question. When we look at this and we say the utilization, we can actually take that population and break it into two big categories. Those who are healthy and no longer need it, and those who are not as healthy. Can we look at that to say, okay, who are the people that we really should be targeting with utilization? Because if I am 20 years old or whatever age and I'm healthy, you really want to see me once a year, no more, because that's about it. That's a hard one. When I was 20, it was hard to get me in to do my annual because I'm young and nothing can happen to me. But there are a lot of others who are older, have a chronic condition, who still don't go in. And if we could target those individuals, now all of a sudden we may find ourselves in a pretty good position. Basically, we're taking our resources, our funds, and targeting them to the needed population.
Yeah, absolutely. And that's, you know, ultimately the goal of our care management programming is to try to identify those individuals that are not just high risk, but are rising risk, or ones that are likely to continue to be in the high risk category. There's a variety of ways we do that based on some algorithms we run across our claims, based on health risk screenings that our care managers do with individuals. You know, I think frankly, this is an area that there's still some opportunity for us. I think especially with a lot of the technology advancements that are out there, there's a lot more predictive algorithms that are getting more and more refined on this. So, you know, that's something that's kind of on our roadmap to look at over the next year, is if there's enhanced tools we can put in place to identify some of these populations and some factors that may be predictive of whether or not they're going to end up in a hospital, so that we can prevent that before that happens, so we're not just defining that risk retrospectively by looking at they've been in the hospital, now we put them in care management. So there's definitely opportunity there, but we definitely look at this by population, by different age categories, by health risk screening, so we cross-reference a lot of data across this.
Thank you.
And I believe we're looking at a new system with Angela, with a whole RFP now for our current system in Battle, so that's part of the consideration, to make sure we have it.
All right, and then our final slide is just an update on claims trends. Again, I think overall pretty steady state here. We're trying to continue to push down the 30 to 60-day category. We have some retro payments that we're expecting from the state for updates to our rates related to 2025, which will help us slow down and push down some of this outstanding claim payments when we get that, which we're expecting right here at the end of June or early July.
Aaron, a couple questions for you. Thanks so much for work and all the hard work that goes into it. One, are there ways that clinicians are being brought along in this environment about some of the changes that may be happening, or things that may be relevant to them? That would be helpful to engage them on, or get perspective about. I think about even experience. I think about just some of the things you're trying to drive growth in, and experience with county care, if they're convened on a regular basis. I know there's written communication that goes out, but there's other ways to engage that community.
Yeah, definitely. We do have some different formal mechanisms. So we have physicians that, for example, participate in our quality committees from external organizations. We obviously have a number of different ways that we go out and have our clinical team connect with clinical teams at different providers, especially in our value-based care arrangements. I think that's a lot more enhanced. And so one of the things we're trying to figure out is, for the groups outside of those value-based care arrangements, how do we drive more of that engagement there? Because we definitely see the differential between the engagement, the relationship, and then the ability to help them focus on a lot of the things we want them to focus on, based on what that relationship looks like. And so, you know, I think I would say I feel pretty good about that structure within our value-based care agreements. And then for the population that's outside of that, we're trying to figure out more ways to engage with the clinicians there. And that's really a matter of kind of resources and volume across that network. A lot of those are smaller providers as well.
Yeah. Thank you.
With that, I'm happy to answer any other questions.
Okay, before Aaron runs away, I just want to take the opportunity to wish him a happy birthday today.
Happy birthday, Aaron.
Thank you. I'm 40 today, so I'm ready for my midlife crisis.
Yeah. There you go. Appreciate it. Happy birthday.
Time for your preventive checkups too.
When? Good morning.
All right, I'll jump right into it. So, HR activity report. There are 1,906 total vacancies within Cook County Health right now. Of those, 154 grant ARPA, 5 are special purpose, 4 for DM or post-grad, and the remaining 1,747 are general vacancies. General vacancies decreased by 260 positions from Q1 to Q2, and it's a 13% decrease in our general vacancy quarter over quarter. Positions in process. So of the 1,747 general vacancies, 61% are in the recruitment phase. Of those 1,063 are, 54% are in the post-validation phase. 163 are interviewing, 257 have decisions to hire in HR, and 149 have offers accepted. Next slide, please. So current state of hiring and separation. 975 offers have been made year to date. 725 have been accepted. Of those, 642 have been filled of those positions. 168 were internal candidates, 474 external candidates. Total separations remain flat year over year at about 250. Retirements decreased by 19%, but resignations increased slightly. Right now, we're reviewing exit survey data to help determine the cause for those, for the increase. Just as an FYI, we are revamping the exit survey process and working with Press Community to launch a full life cycle survey of employees from start to end of their employment with CCH. The exit interview data that we have from June 1 of last year to May 31st of this year shows the following. We got about 35% response rate over that 12-month period. 42% left for personal reasons, 31% were for the working environment, 10% for compensation, hours, and benefits, and about 6% were for job demands. We are currently at 224 net hires, and that's about a 91% increase compared to this time last year. Next slide.
I'm sorry, you said it's a 91% increase?
91% increase over this time last year.
All right. Good work.
All right, so nursing activity. We have 199 filled nursing positions, 70 non-RN, 11 nurse leaders, 118 direct care RNs. 31% of those were internal candidates and 69% were external candidates. And then the next one, oh, there we go. Thank you. We've made 223 offers, 150 were accepted, and 71 were external hires. With that said, I want to move on to the next slide to talk about our accelerated hiring process. I know some of you are aware of this. We piloted this last year in nursing. We're expanding it now throughout the organization.
I got a quick question.
Sure.
I think there's an interesting nuance to all this that probably the hiring thing is that we seem to do pretty well with internally filling positions, which then creates a downstream effect, correct?
Yeah.
So I think that's an important thing to know, that we make progress in hiring, where there's also a little bit of drag on overall filling of vacancies because we're hiring up into higher level positions or into other departments, which then it doesn't eliminate the vacancy, it moves the vacancy down.
It just moves it down the
sort of neutral, right? Because you still have to go through the same HR process. I think it should give us all an appreciation that, you know, you guys have to chase a little bit more to actually reduce the vacancy number, because you are hiring, you have to, you basically, for some of our, whatever the amount of positions, it's like a double interview process.
Correct.
Right.
But it's a good challenge to have, because we've also sat in these meetings, I've heard about more opportunities for people to have upward mobility, and you're reflecting that in the report.
It's actually, it's not a problem, because I think it's because I probably more than anybody believe in that, right? I don't want to say that, but I certainly believe in that. But I think it's also something for us to, or it also builds, you know, having people move upward within the organization improves morale quite a bit, promotes culture, but it does put it is a little bit of a, it's a hidden challenge, I think, to most people when it comes to how you guys have to operate and why things sometimes look flatter than they should be while you're making progress.
No, I appreciate that. And you're absolutely correct. Being able to hire internally and move people along will lead to better engagement long-term, throughout the business.
And my question was relative to that. What feedback do staff get regarding that potential longevity of the career trajectory and that move of when folks may be hired, and then the ability to be able to then increase to either higher, differing, or progressive rates? Do we have a factor or an indicator that would be, that we could either derive from that, and then also to be able to report back to staff
Yeah, I could probably
in
look
regard to
into,
that kind of novice to expert?
I could look into our employee engagement data to see if there's any specific comments about that, and to see how those questions play into that. But typically, as you know, when employees feel that there's room for them to grow, they're going to stay with the organization. We already have a pretty low turnover rate, but we also want to give people the ability to move throughout their career. And when people see that, and they see this, like, Bob's advancing, or Dr. Sorrell's advancing, they know that there's a place for them as well.
It's nice, though, to be able to have that as a indicator or a benchmark, though, not only as part of when folks are hired, to say, you know, 90% of folks that start here, in 20 years, they're still here, and then they've gained, you know, additional expertise and activities. But that's also particularly for nursing, so that when folks make decisional ideas, because we know we have that, how many people are interviewed or offered a position versus how many are accepted. That would be an excellent indicator for those that are offered a position to recognize, hey, this is a place where you can have that longevity of career.
That's a great question.
Okay.
Yeah, and I just want to follow up on what you're saying, Director Sorrell. I mean, if you go back and look at the feedback and it's not there, then we should seek that feedback so that we know what the awareness is about this kind of positive outcome.
I have a question too, because you're working really hard to fill the vacancies. But when I look at the resignations, I see a 17% resignation from the previous year. I would be curious to understand why that's happening, because it hurts your efforts on the other end.
Yeah, so I think that's part of one of the things we're working on. We do have our resignation data, or we have our exit interview survey. It's not, for me, I don't believe we've got a great capture of the amount of people who left, because we've only got about 35% of the people who left filled out the exit interviews. You don't always get people to fill those out, but what we're doing is we want to understand what makes them happy when they come in, why they joined, and then we want to understand, you know, from full life cycle, from the time they started to the time they leave, what's going on within there. So we're going to be surveying people more regularly throughout their life cycle, being here at CCH, really starting at the beginning, and then at 30 days, 90 days, in that first year, because making sure that the employee engagement is captured in that first year is going to give them better opportunity to keep them engaged throughout their career. But to your point, we've got to dig in a little bit deeper and understand why we've had that uptick. What we have seen is that most of the people are leaving for personal reasons, but the question is not the right job for them anymore, has something else happened in their personal life. We have some people leave because of the work environment, so we've got to dig in a little bit more there. So some of the data is giving us the opportunity to ask the great questions, but we've got to better understand what's going on.
And the other thing would be, is that spread across all roles, or is it in particular aspects of the organization.
That's the other piece too, I want to dig in and understand, is it more in a certain area, are we seeing this, in more professional roles, so that's data that we're still extrapolating.
Okay.
It's not the best, especially with such a small sample size, but I think that we can get better as we move through this.
So for clarity on this, though, our turnover rate is extremely low.
Correct.
So that's 17% of that low turnover rate. So, how do we compare that turnover rate? How does that compare to other institutions, other healthcare institutions?
I'd have to check on that because I don't have that on me. I do know that government has typically a lower turnover rate because of some of the pieces we have. When I was at, this is actually lower, and I'm surprised, lower rate than I was at Metro. So at Metro, we had a little less than 10%. I think here we're at about 4%. I know they're not apples to apples, but from the government standpoint, this is lower than those.
Yeah.
Okay. Moving into accelerated hiring. So the accelerated hiring process is a targeted recruitment strategy designated for designed to expedite hiring for critical roles within a impact operations or patient care. For the purposes of expedite hiring to high volume, entry level, and low qualification positions to avoid operational delays. Any position is eligible as long as there are multiple vacancies in a single posting for specified role. It will require department head or designated approval. Talent pools include nurses, environmental service workers, technicians and technologists, food service workers, medical assistants, and we're really targeting agency workers as well. From a process standpoint, the posting time will move from typically a minimum of 14 to 5 days. Screening is going to be a preliminary eligibility list sorted by category. So internal, veterans, agency workers, and interns. And then external. Candidates will be selected directly from the validated eligibility list, and offers are made based on the order of appearance on the validated eligibility list. Priority is given to internal, veterans, and then agency workers. So it's a bit of a heavy lift to get this in place. We are rolling this out now. We're being very careful on how we do it to ensure that we do it the right way. We don't want to break any rules. We want to make sure that as we roll this out, any learnings that we learn over the first group, we can apply later on as we do this.
Chief, let me say, I'm sorry, Chair, may I? Thank you. Chief, let me say this is a game changer, and I want to applaud you and your team for bringing this before us. This will help ensure that we are the first choice for many, and as we should be, but historically, because of delay, maybe we weren't. So I just want to shine a light that this is very significant, and thank you.
Thank you for moving so quickly to implement this.
Thank you.
No further question, a good report.
By the way, when was the last time someone in human resources job got a round of applause?
I know, right?
I mean, most days you feel like you're getting your teeth kicked in, don't you? From both sides.
That'll be next month, so.
Yeah. This is somewhat, I'm someone who still has some HR director's teeth in my foot.
Every now and then. That said, it's almost an appropriate time. Now I like to actually take this opportunity to provide my last report as the chair of this board. It's been a tremendous honor and privilege to serve as a board member and chair of this board for the last 4 years. As you highlight, I've observed tremendous growth and progress. There's a gospel song that's in my head, like when I look back over my life and I think things over, right? I can truly say that I've been blessed. I have a testimony. I think this institution has a testimony, and it's been a privilege and honor to be a part of this. And I'd like to thank Dr. McItis, the whole leadership team, the doctors, the nurses, the admin staff, the researchers, everybody from Jorge, right, in Parkey, to those who help us. I'm off script, Debbie, I know. And I like to think like Sam. Thank you. Those who support this board, who don't get the recognition, right? Who help us do the work that we do, to the work that we need to do. Alicia, thank you. Jeff's not here, but Jeff's on screen. Thank you very much, personally. And Debbie, Debbie talks to me every other day. So you think we talk? There's a lot of work that happens outside of this. And this board and everyone knows that we can do this without Debbie. So Debbie, thank you publicly. And finally, I'd like to thank all the directors. When you choose to do this, you choose to invest your time, your talents, your wisdom to support the work that this organization does to provide quality care for all. Think about our mission statement. Thank you. I appreciate it. And you do it uncompensated, which most people don't know. So we all appreciate it. I thank you. And again, it's been my honor and a privilege to work and serve alongside each of you. Thank you.
If I may,
if you could stop me. Lyndon, just the structure of our meetings and how efficient we've become as a board without sacrificing transparency or discussion, I think has been much appreciated by those of us who've either been on the board or staff, because it allows us to do the things that make an impact. Having the ability to not spend all our time in here hearing reports, the same report over and over again, but having being able to dive deeper into the issues and still get out of here at a time for people to go back and attack the challenges that they have every day. So I appreciate your leadership and your ability to see the big things and the small things.
so if I may, Chair, I spoke to you years ago and met you before you said yes. And I'm so glad you said yes. But because I'm old, I still have paper. And I do have a system to my paper. And I looked at my notes from our initial phone call. And you said if you did this, you'd be present and collaborative, and you said you'd give it your best. And I just want to say thank you for doing all three of those things and more. We appreciate it.
Yeah, I personally want to commend you for keeping us on task, keeping us focused, and getting us through some tough times and some tough issues. And the good thing is I have your cell phone number, so I will be able to call you when I have questions.
I'm sure you will.
If I may, Mr. Chair, thank you so much for your leadership, your contributions, just how you lift up this community and board and the people that work for this institution through these meetings. And I think we've learned a lot. I've learned a lot through your leadership, and appreciate all your time and effort and contribution. Thank you.
2 years. We vaguely knew each other beforehand, I think at a couple of meetings here and there, maybe seen each other. I've enjoyed it. I didn't know this was your last day. Didn't know that. But I think I'll miss most of all your humor. You have a very interesting humor that brings a lot of laughter. The organization, I think, has already been stated well by Bob, but the humor, I'll miss that.
I want to say thank you too. You helped me understand the board and, bullying these things. So I really appreciate it. Thank you.
In particular, for those of us who were new to joining the board, your ability to help us see the larger picture, while we may sometimes find our way to the weeds, and then indulging us, as I mentioned in talking with you, in being able to ask these questions. Because all of our combinations of strength and knowledge and skill base, when we don't route these appropriately, we can't move in the direction to really be able to make the improvements and make the enhancements that will highlight and move us forward. You've been able to not only corral our questions, but also to empower our questions in being able to do that. So thank you so much for your work.
Agreed, and closer, Mike. Thank you so much.
Director Webster Cross, you had your hand raised?
Yes, Chair Taylor, I just want to say I'm just really sad to see this chapter close for you, but I'm incredibly grateful, for your leadership, your commitment, and always putting the mission and the people first. So thank you for your service, and your presence is definitely going to be missed. but I wish you well.
Appreciate it. Thank you. Although I will not be, as a board member, you know, I'll be continuing my association and supporting this organization and the work you do, and as they say, cheering from the sidelines, forever. So, for those of you who do have my cell phone, you can call judiciously. Appreciate it.
If I may, Chair Taylor. Please. Thank you. As is our tradition at CCH, when board members transition to the next step, we present them with a picture of the old county hospital so they can remember their time with us. Before I do that, though, for those newer team members in the room, I just want to tell everyone a little bit about Lyndon. So since coming into the role of chair in 2021, Chair Taylor has led with vision, steadiness, and compassion during one of the most pivotal periods in our health system's history. We came out of the depth of the COVID-19 pandemic, which was a time that tested every corner of our organization and our community. Chair Taylor brought a clarity of purpose and commitment to equity that helped guide us forward. And under his leadership, we didn't just recover, we started to transform. We expanded services and invested in new models of care and embraced innovation, all with a continued focus on serving the people of Cook County with dignity, quality, and compassion. He challenged us to think strategically and boldly about our future, always grounded in our mission. He brought a combination of thoughtful governance and deep humanity to the role. And that made a lasting impact, not just on the board, but on every employee, provider, and patient who counts on this health system. Lyndon, Lyndon, on behalf of the entire executive team and all of us at Cook County Health, thank you. Thank you for your leadership, thank you for your wisdom, your integrity, and your unwavering commitment to our mission. And on a personal note, I want to say thank you for your guidance and support as I move into this role. On behalf of the entire team, we're deeply grateful and wish you all the best in the next chapter. You'll always be a part of Cook County Health.
Thank you. Okay, I'm gonna get through this. We appreciate it. We will now move on to the annual meeting business of election of the chair and vice chair. I'd like to open the floor to nominations for chair.
I'd like to nominate Raul Garza for chair of the Cook County Health System Board of Directors.
Thank you. Thank you. Are there any other nominations from the floor? Thank you. If chair, my notes. I told you I'm gonna get through this. As there are no other nominations, the floor is now closed, and we'll vote on the matter of election of Raul Garza as chair. All in favor? Aye.
Aye.
Thank you. All opposed? The ayes have it. The motion to elect Raul Garza as chair carries. Oh, Raul.
So, Lyndon, I chose to save my remarks until I was elected as chair. Make sure you got the votes through first. So now as a chair, let me go back to honoring you. So much has been said about you. I mean, what's left to be said, but this, you've always been thoughtful. You've been pragmatic, and but you've been meaningful. And I think from where I sat, I've learned a lot from you. Having served, I think, as long as Joe and Bob, I mean, you beat us all by probably 5 years or something like that, which is why you get the floor a lot. But no, I really, it's not just big shoes to fill in the role itself, but the shoes that are vacated by you to be filled. And I'm honored, and I've had an opportunity to serve on a lot of boards, but there's no greater distinction in serving on this board and following the work that you've done. So thank you for everything that you've done for me professionally, and I know we've had some personal conversations too, so I appreciate that. Thank you. And I just have one item in this first action in my role, and that is to ask if there are nominations, if there is a nomination for the vice chair role. So the floor is open to offer a nomination for vice chair.
I'd like to nominate Commissioner Bill Lowry as vice chair of the Cook County Health System Board of Directors.
Second.
Should I leave the room?
Is there a second? Okay, there is a second. And are there any other members to be offered for this opportunity as well? Okay, hearing none, I'll take the vote. All in favor, say aye.
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 Thank you. All opposed? And that motion carries. So congratulations to our colleague, Commissioner and Vice Chair Lowry. Thank you.
Thank you.
Thank you.
I want to say thank you to all of you, but also Chair-elect, please know I am here to assist you in any way which you deem appropriate.
Thank you. Thank you, Vice Chair. I look forward to your support as well as the other directors. Thank you. And so the board will not be going into closed session today, so if there are no other questions or matters to discuss, we can move to adjournment of the meeting. So I'll ask a motion to adjourn.
So moved.
Second.
Second, all in favor?
Aye.
Any opposed? Thank you. Have a great weekend. The meeting is adjourned. Thank you.
Directors, before you walk away, we're gonna get pictures with the whole board. If I can have, Raul, Lyndon, and Eric sitting at the table, and the rest of the directors standing behind them.